Welcome back to the Deep Dive. We're here to sift through your sources and pull out the key insights. Today, we're heading to Malaysia, taking a close look at their, well, pretty comprehensive and sometimes pioneering approach to HIV/AIDS prevention.
Yeah, we've got a fascinating stack of sources here. They cover everything, really. Foundational public health stuff, some cutting-edge strategies.
And even some really unique ways they've integrated cultural aspects, which is quite interesting.
Exactly. So our mission today is to unpack how Malaysia tackled this epidemic. We'll look at their successes, which are sometimes quite surprising.
How they adapted their strategies over time.
And of course, the challenges that still remain. Get ready for some real insights, because this is where it gets really interesting.
Definitely.
Okay, so let's kick things off. Where do we start? Maybe with one of their most inspiring successes, protecting mothers and babies.
Absolutely. The PMTCT program, Prevention of Mother-to-Child Transmission, launched way back in 1998.
Right, 1998. And this wasn't just, a basic test. It was comprehensive, totally. Counseling, routine HIV and syphilis testing, ARV prophylaxis, safe delivery, the whole package.
And follow-up care, too, for both mom and baby.
Yeah.
And the key thing seems to be how they rolled it out, targeting pregnant women in government clinics.
Yes, using a universal opt-out screening method. So basically, everyone was offered the test unless they specifically said no.
Which likely boosted participation quite a bit.
Hugely. And always coupled with pre- and post-test counseling. That support piece was crucial.
So what was the big achievement here? The sources mentioned something pretty significant.
Oh, it was monumental because of this integrated approach, embedding it right into standard antenatal care. Malaysia actually became the first country in the West Pacific region.
The first? Wow.
Yeah, the first to eliminate mother-to-child HIV transmission as a public health problem. That was back in 2016.
Eliminated as a public health problem, meaning they got transmission rates really low.
Exactly. Below 2%. And that success really hinges on that deep integration, plus high RT coverage and, critically, working closely with NGOs.
That's incredible. An amazing achievement. But, even with that success, what are the ongoing hurdles? Does ensuring access for, say, marginalized groups remain tough?
That's spot on. Sustaining success is always the next challenge. Reaching those harder-to-reach populations definitely requires ongoing, targeted effort.
And just keeping those rates low, maintaining the system.
Right. It needs continuous funding, vigilance.
Yeah.
It's not a one-and-done thing.
Makes sense. Okay, so shifting from prevention in pregnancy, let's talk about broader diagnosis. VCT, voluntary counseling and testing.
A really vital piece of their strategy. It's seen as the main entry point into HIV care across the country.
And accessible, it seems. Government health facilities.
Very accessible. And smartly integrated, too. Linked with antenatal care, TB services, STI services.
You go for one thing, you might get offered testing for others, too.
Precisely.
Yeah.
And the process is straightforward. Pre-test counseling, the test itself with informed consent, of course, and then post-test counseling based on the result and the person's needs.
And who are they targeting with VCT? Is it just specific groups?
Well, yes and no. They definitely focus on key populations, sex workers, people who inject drugs, but also antenatal mothers, really anyone. They even offer anonymous testing.
To encourage people who might be hesitant.
Exactly. Lowering barriers wherever possible.
But even with all that, the benefits of early diagnoses are clear, but what were the difficulties? The sources mentioned some persistent issues.
Yeah, this is where the social side really kicks in. Stigma, fear of discrimination. Those are still major hurdles.
Leading to lower testing rates among some groups.
Unfortunately, yes. And outreach is another thing. Despite good availability overall, getting services consistently into, say, remote rural areas is still a challenge.
Right, the last mile problem. Okay, moving on to another area where Malaysia seems to have been quite forward-thinking, harm reduction, especially for people who inject drugs, PWID.
Ah, yes, the harm reduction programs launched back in 2005, a really pragmatic move.
And focused on two main things, right? Needle exchange and methadone.
Correct. The Needle and Syringe Exchange Program, NSC, and Methadone Maintenance Therapy, MMT, or sometimes called OST, Opiate Substitution Therapy.
The needle exchange, mostly run by NGOs.
Primarily, yes. About 78% NGO-driven. They provide clean needles, safe disposal, but also, crucially, referrals to VCT and MMT-OST.
So it's not just about needles, it's a pathway to other services.
Exactly. And the whole point is reducing HIV transmission without actually encouraging drug use. It's a fine line, but a necessary one.
And the MMT-OST side seems incredibly widespread, 838 centers.
It is. Hospitals, clinics, even prisons.
Right.
The aim is to reduce dependency on narcotics and consequently the risky behaviors associated with it, like sharing needles.
And it works.
The evidence is strong. Studies like MyTOS 2018 confirmed it helps reduce HIV infections, drug use, even related crime.
It sounds very effective, practically speaking. But connecting this to the bigger picture, what were the hurdles? Was it easy to implement?
Far from it, initially. There was significant community resistance, the whole not in my backyard sort of thing.
Stigma again?
Huge stigma against people who inject drugs. That really hampered things. Plus, the usual challenges. Getting good coverage in rural areas, needing sustained funding, and ensuring that NGO government collaboration works smoothly.
It really highlights that public health isn't just science, it's social navigation too.
Absolutely. You need community buy-in.
Okay, let's shift gears to some newer tools. Pre-EP, pre-exposure prophylaxis. Many listeners will know this HIV-negative people taking daily meds to prevent infection.
Right, a key biomedical tool.
Yeah.
And Malaysia's incorporating it strategically.
Targeting specific groups.
Yes. Men who have sex with men, NSM, transgender women, sex workers, people in relationships where one partner is positive and the other isn't serodiscordant couples.
And they have their own model, ABCD.
They do. They've adapted the classic ABC abstinence, be faithful, condom use, and added D for drug, meaning pre-P.
Clever, and it's rolling out now.
A pilot project launched in December 2023, started in 18 clinics, already expanded.
Any early results?
Promising ones. Around 3,500 clients enrolled by late 2023. They saw syphilis rates drop among participants and increases in condom use and monogamy.
And crucially, HIV infections.
Very few. The seroconversion rate among those on pre-POP was remarkably low, just 0.2%. Shows it works when taken correctly.
That's highly effective. Now, what's fascinating here, you mentioned unique cultural integrations earlier. How does that play into PP?
This is where Malaysia's approach is quite unique. They proactively engaged with religious authorities, JAKIM, state fatwa committees.
To get their buy-in for something like pre-P.
Exactly. To ensure sociocultural acceptance. It was a crucial step to avoid backlash and frame it positively within their cultural context. They didn't just launch it medically, they built social understanding.
That's really smart, preempting potential conflicts.
And they stressed confidentiality and the health for all principle, non-discriminatory access.
Okay, but even with effectiveness and this careful rollout, challenges remain for pre-P, right? The sources mention a few.
Oh, absolutely. Awareness is still relatively low in some communities. Adherence taking the pill daily can be tough for people.
And those cultural or religious concerns haven't entirely disappeared. Some people might still see it as enabling risky behavior.
That perception does linger, yes. And sometimes even healthcare providers might be hesitant to prescribe it. Lots of education still needed.
So availability isn't enough. You need the uptake and the support systems.
Precisely.
Right. Another innovation tackling access and privacy. HIV self-testing. HIV-ST. Testing yourself at home.
Another game changer, potentially.
Yeah.
Launched alongside PREP, December 2023.
And they have principles for this too, the 5 C's.
They do. Consent, confidentiality, counseling, correct results, and connection to care. Each C is a vital safeguard.
Makes sense. You need guardrails for self-testing. Who's it aimed at?
Particularly younger people, 18-30, pretty easily. Online platforms like testnow.com.my, the My Sagittara app, they can get kits delivered or pick them up.
Sounds convenient. There's an online assessment involved.
Yes, a risk assessment. If someone flags as high risk, they're guided towards confirmatory testing and proper clinics.
Is it catching on?
Looks like it. In just the first few months, the Yosemite to Mar 24, nearly 27,000 website visits, over 12,500 assessments done.
Wow. And the stat about first-time testers.
Yeah, 62% of users had never tested for HIV before. That's huge, reaching a whole new group.
That is impressive uptake, but there must be limitations, right? What are the potential downsides of self-testing?
Well, the big one is, a single rapid self-test isn't a final diagnosis. You must get a confirmatory test in a clinic if it's positive.
And people might not follow through.
That's the worry linkage to care. Also, digital literacy is a factor for accessing the online parts.
Yeah.
And psychosocial support. What happens if someone tests positive alone at home? Do they have immediate support?
That's a critical point, and tracking the data must be harder if it's self-reported.
Exactly. Challenges for public health monitoring.
So innovation creates new complexities to manage. Okay. Complementing self-testing, there's also community-based testing, CBT, taking testing out to people.
Right. Beyond clinics, into community settings, drop-in centers, mobile vans, community events.
Run mainly by
NGOs and outreach programs mostly, offering rapid tests, counseling, and that crucial linkage to care right there on the spot. And this really fits into their national goals, doesn't it?
Absolutely. It directly supports Malaysia's national strategic plan goal of getting 90% testing coverage among key populations.
The benefits seem clear. Easier access, less stigma than maybe a formal clinic.
And catching infections earlier. But the challenges? Funding, I imagine.
Funding is always an issue, especially consistent funding.
Yeah.
Logistics, too, particularly reaching rural or scattered communities.
Right.
And needing enough trained people to actually do the outreach. It's very resource intensive.
Real boots on the ground work. Okay, so we've talked about specific programs. Is there something that ties these together, especially for key populations? The DHSKP?
Ah, yes. The Differentiated HIV Service for Key Population Program. DHSKP. This is really a cornerstone initiative.
Differentiated meaning. Tailored.
Exactly. Client-centered. HIV and STD services specifically designed for the needs of key groups, MSM, transgender people, sex workers, PWID, even prisoners.
And it's part of their big national plan, too. The one aiming to end AIDS by 2030.
A central part of it. The goal is reducing transmission, boosting treatment, tackling stigma, all by customizing the services.
And collaboration is key here, too. Public and NGO.
Very much so. The Ministry of Health works hand in glove with the Malaysian AIDS Council and other NGOs.
How does that work in practice? Who does what?
Generally, NGOs handle the outreach, the case management, building trust. MOH clinics focus more on the clinical side, diagnosis, treatment, labs.
And it's peer-led. That sounds important.
Hugely important. Having trained peer educators from within those communities doing the outreach, it builds trust like nothing else. It helps ensure people stay connected to care.
So this DHSKP is designed to help them hit those big targets, the 95, 95, 95 goals.
Precisely. 95% knowing their status, 95% of those diagnosed on treatment, 95% of those treated virally suppressed. DHSKP is the engine driving that for key populations.
But like everything, challenges persist. Stigma even within clinics sometimes.
Yes, stigma doesn't just disappear. Ensuring clinics are truly welcoming spaces is ongoing work. Sustainability is another big one, moving from global fund support to domestic funding.
And just keeping that NGO government coordination running smoothly.
Constant effort required. It's a complex partnership.
Okay, that makes sense. Now for something really unique, we touched on earlier that blend of public health and cultural values. Premarital HIV screening.
Right. This is quite specific to Malaysia, particularly for Muslim couples, though it's now offered voluntarily to everyone.
And it's mandatory for Muslim couples planning to marry.
It has been, yes. Integrated right into the marriage application process. Done at government clinics a couple of months before the wedding.
Includes counseling, too.
Yes, pre- and post-test counseling, just like VCT.
Why is this seen as so important there? What's the rationale?
Several layers. Preventing transmission to a spouse or future children, obviously. Encouraging responsible decisions, blending medical advice with religious guidance.
And potentially reducing stigma by making it normal. Routine.
That's a big part of the argument, yes. Normalizing screening by making it a standard step before marriage.
The sources gave an example. If a male partner tests positive,
He gets linked to care immediately, receives counseling, including religious guidance. Then the couple makes an informed decision about the marriage, knowing the situation and the precautions needed. Confidentiality is strictly maintained, of course.
it's a really striking example of integrating health into a major life event, shaped by cultural context.
It really is. It shows how they've managed to frame a health intervention not just as a medical necessity, but as a social and even religious responsibility. That's quite a feat, achieving that level of buy-in and normalization.
Definitely a unique approach. Okay, so pulling back to the big picture. All these different programs, PMTCT, VCT, harm reduction, pre-APP, self-testing, community testing, DHSKP, premarital screening, they all feed into the National Strategic Plan, right? Ending AIDS 2016-2030.
Absolutely. That plan is the umbrella. It has those 4 core strategies tying it all together.
Which are, refresh my memory.
Enhancing testing and treatment, improving prevention for key populations, actively reducing stigma and discrimination.
And having good data, monitoring, evaluation, research.
Exactly. Robust strategic information. That comprehensive framework is what guides all these diverse efforts and allows them to track progress.
Wow, what a deep dive that was. We've really covered a lot of ground, from that incredible success with mother-to-child transmission,
Which was truly pioneering.
to their pragmatic harm reduction work, and now these newer tools like pre-AP and self-testing, and all of it woven into their specific cultural and religious landscape. It's impressive.
It really is. It underscores that tackling something as complex as HIV isn't just about finding the right drugs or tests. It's about policy. It's about deep community engagement.
And really understanding the society you're working in.
Precisely. Combining the biomedical with social responsibility, targeted outreach,
Yeah.
that seems to be the recipe for impact in the Malaysian context.
So, for you, our listener, maybe a final thought to chew on as we wrap up. We live in a world struggling with complex health issues, often tangled up with social barriers and diverse values.
Hmm.
How might other countries learn from Malaysia's integrated, culturally attuned approach? Could adapting some of these principles help achieve breakthroughs elsewhere, especially for challenges that seem deeply entrenched in social norms? Something to think about.